So at the back, you can find cookies from Freedom a la carte. Freedom empowers and helps victims of sex trafficking and exploitation. So I'll pass the floor to Jane, who is the special event specialist at the SCI office. So she'll give us a brief introduction of the panelists. So I'll pass the floor to Jane. Thank you. And I hope you will enjoy this.
Thank you, Tiachi. So we all know Women's History Month is an excellent time to reflect on triumphs of women throughout history. It's also a great time to explore challenges that we are still facing. So during this panel discussion, we're going to talk about some women's health inequities and disparities, some areas that may still need to be advocated for. So I'm going to go ahead and introduce our three panelists. So our first panelist is Dr. Marian Jones, and she serves as an associate professor at Ohio State in the College of Public Health and Division of Health Services Management and Policy and the History Department. Our second panelist, Dr. Dia Boster, serves as an associate professor of history in the Humanities Department and teaches U.S. history and history of Western medicine. And last but not least, our last panelist is Dr. Nicole Bowman Glover, who has served as a well-being benefits analyst for over 15 years and has over 25 years in the field of public health. So feel free to check out their full bios on the website listed behind me. But for the sake of time, we only have an hour and we've got some really awesome discussions. So I'm just going to jump into these questions. And just a reminder, you're welcome to jot down any questions you might have, or if you're on Zoom, you could put them in the chat and we'll make sure that we get those questions asked. Okay, so to get us started in talking about women's health, for maybe those who are not very familiar with the field, what would be like an overview? What is meant by Western medicine? What is the field of public health? And anyone is welcome to start off, and more than you can add on each other, whatever works.
Well, I'd be happy to address what is Western medicine. Because West, when you think about it, is a very ethnocentric term to describe any part of the world. If you accept that we live on a spherical globe, you might immediately think, well, west of what? And the term's actually been used for thousands of years. It initiated in Greece when Greeks began to interact with people in the Near East, in the Arabian Peninsula. So they would identify themselves as being in the center. If the sun sets over Europe and the sun rises over the Near East, then they must be more towards the West, right? And initially that term meant just the Mediterranean region, but it now kind of encompasses primarily Europe, the Americas, as well as, influencing many colonial and post-colonial parts of the world too. So when we talk about Western medicine, we mean ideas about disease, about health, about treatment, medical professions, medical remedies that originated in those so-called Western countries. But, there is no real geographical boundary that identifies Western medicine.
And then as far as public health is the study of populations. So when we talk about health, we're looking at the health of different kinds of populations.
Yeah, and I think it's important to think of what's interesting with Western medicine is about the health of individuals. And it's very tied to individualism, that European, Eurocentric idea of, the individual and as the center of everything. And if you look at, I'm not an expert on Chinese medicine, but I do know a little bit that it's not as much about an individual. The idea of collective and individual are less, are not opposed to each other. So I think because of the Western medicine idea of, being focused on treating the individual body and treating disease in the body, and it being based on anatomical studies of diseased bodies, public health arose as sort of a counterpoint to that, to talk about, let's go backwards and prevent disease from occurring, and let's not just look at the individual, let's look at the community and the population and the causes of disease not being just biological within your body, but within society, within the community. You know, everything from air pollution to lack of access to parks, to lack of access to healthy and safe places to be as a child, you know, to, you know, lack of clean water, are public health issues that are going to affect our health collectively. And lastly, I'd always say for college students, you know, if you live with your family or you live with roommates, you know that we affect each other's health. If you have that unhealthy roommate, you know, we've either been or we've had that unhealthy roommate, you know, who like wakes up at 2 in the afternoon and eats Cheetos for breakfast and whatever, you know.
You're not supposed to do that, really?
I said either had or been. I'm
yes,
not
I know.
that I have been, but you know,
yes. No, that's the point.
We are all affected by other people's behavior. That
yes.
I'm going to be less likely to do my getting up at 6:30 and doing my, you know, exercises and meditation and wellness stuff if my roommate is doing that, and all my roommates are doing that, or my whole family is doing unhealthy behaviors. And maybe because of factors beyond their control, because people have to work 2-3 jobs.
Yeah.
So that's, to me, that's public health. It's looking beyond the anatomy, the biology, the individual, to the community and society.
Oh, that's a great analogy. Yeah. I never thought about that, but I'm sure we can all relate to that, the people that we live with.
Okay.
Did you have something you wanted to add?
Well, I also just wanted to point out that when we talk about women in medical history or women in medical research or any kind of scientific research, really, the overwhelming majority of individuals who are classified as women in that research are those who are cisgender women. They are people who are assigned female at birth, but clearly there are people who identify as women who do not fall into one or both of those categories. There are people who fall into those categories that don't identify as women. But when we refer to women's history, that's generally been up until the 21st century, that's been the population of individuals that they're talking about.
Okay. That actually has a great start into my next question, which is, so historically, what research has gone into women's health from like the scientific community or the medical community? What has that looked like throughout any period of history?
Well, do you mind if I
No,
jump
ahead.
in? Okay,
Go ahead.
For thousands of years, when you look at Western history in particular, but really in a lot of different parts of the world, women have been intimately involved in caregiving, right? And the historian Laurel Thatcher Ulrich calls this social medicine, the idea that lots of caregiving from birth to death, literally, whether it's attending a childbirth to, you know, hospice, what we today would call hospice care, to preparing a body for burial, that has been the vanguard of women. But it's gone largely unrecorded. It's really not until the modern age that you begin to see more systematic exclusion of women from caregiving. And one of the earliest examples of this was the rise of what's called man midwifery in the late 1700s, okay? Now, for centuries, thousands of years, women had fulfilled roles as midwives, right? The ones who were not just providing, you know, perinatal care, but also early pediatric care for children after they've been born, as well as other sort of general practice. But then, beginning in the late 1700s, male university-trained physicians began making a case for their need to be involved in what today we'd call obstetrics and gynecology. Which, as you might imagine, was quite controversial. If you look at this engraving, this is a British image from the late 1700s, kind of, you know, calling attention to the gender transgression of these man midwives, that they were, you know, male physicians stepping into a female-dominated practice. And some people have said that this transition was largely due to the invention of obstetrical forceps, which is an instrument used for extracting infants in problematic childbirth situations. That's probably not true, although having that technology did seem to help male physicians if they kept the training in using obstetrical forceps to themselves. But really this coincides with the rise of scientific medicine, understanding medicine less as a spiritual, domestic, or philosophical matter and more as an academic and scientific one. And you really see this over the course of the 19th century with more men stepping in to conquer disease, right? Disease doesn't just become something that is tended to at home. It is something that is studied in laboratories. It is something that is treated in clinical institutions. And that also will lead to kind of a regendering of caregiving, more to the male side than to the female side. So that's where I would start. I don't know if anyone wants to jump into that question too.
Well, I would jump into also, so when then medicine, scientific medicine, and also professional medicine, the profession of medicine starts to rise, and it's a money-making profession for men. They go to a medical college, they pay, then they come out and they are doctors, and there's no health insurance. In the 18th century, say early Republic US, they have paying patients. And so what Dia said about having forceps was one way that they could sort of advertise, if I'm a woman and I'm going to give birth, should I get the local midwife or should I pay for this doctor? Well, the doctor has not only forceps, but also is more willing to use drugs and do bloodletting and other things, which at the time were considered to be potentially beneficial for the women. And that also leads to men's involvement in medical research on women's reproductive systems and on reproductive conditions. And the most notorious of these is Dr. J. Marion Sims, who in Alabama and elsewhere conducted research on enslaved women, and he also conducted some research on Irish immigrant women. And it was without anesthesia, and anesthetics were available at the time, not modern anesthesia, on something called obstetric fistula, which is still a global problem, that it's a complication of childbirth that leads to basically uncontrolled urination and there are tears in the genitourinary area. And so how to repair that, and so he experimented on non-consenting enslaved women, 3 women whom we know only by their first names, Anarcha, Betsy, and Lucy. And there's a slide actually, because J. Marion Sims for decades maybe centuries, was lauded by Western medicine, by American medicine, as the father of American gynecology, because he did develop these operations that were then applied to white women who were paying patients. And yet the women upon whom he had experimented suffered, chronic pain, complications. It was, by any contemporary notion of human rights was a dire violation of human rights, right? And ruined. And so, yes, this is the J. Marion Sims statue. So he wasn't just lauded in the South, in the enslaved, in the slave states. He was lauded in New York City, and there's a huge statue of him in New York City. And it's only recently, that there have been protests against that statue. There's one there.
This is 2019, I think.
Right, a protest against that. And moving on from the protest, then in Montgomery, Alabama, just this fall, a really impactful group of statues was dedicated very close to where Sims did his experiences, called the Mothers of Gynecology. And I haven't seen it yet. I'm going down to Atlanta in May. I'm hoping to take a little detour and go there. And it's not only, it's the beginning of this. So not just, this is horrible, and remembering this horror, but moving beyond it to recover the names and the legacies of these women who contributed against their will, but they were the ones who contributed to the development of understanding, obstetric fistula and how to treat it. And also the organization that has been involved in creating these statutes has also been it's the first step toward then an education center and a program to educate activists for racial justice and equality around health. So it's moving beyond just exposing the horrors of the past to also how can we move forward and how can we train the next generation of people who will be health activists.
And I think that raises the interesting point, the very important point, that we tend to think of scientific medicine as objective, as above, the biases or discrimination in society. And it simply is not. And even, you can definitely see this today, and you can see it in the past. When you look at 19th century gynecology, the time that Sims was doing this, there were a lot of assumptions about which women would be appropriate as research subjects or as test patients. And I've actually got a great slide of a 19th century OBGYN exam, or there is one up there that we were all talking about earlier.
Oh, sure.
Yeah.
This one?
This one, yeah. So, when you think about this shift towards men's involvement in women's health, particularly reproductive health, in the 19th century, it was considered improper for well-to-do white middle or upper class women, Western women, to be seen in such intimate situations by male doctors, right? So in a gynecological exam, a male physician would work with a patient who was fully clothed, not actually looking at any of the bits involved. And, so you can imagine the limitations of that. And if this kind of clinical encounter was considered a bit extreme, imagine what it was like for researchers or medical students who were trying to learn how to do this in a lot of medical schools, which by and large did not accept women throughout the 19th century. And those that did accepted them under very limited circumstances. They even had separate gross anatomy labs so that the women would be dissecting cadavers separate from the men because it was considered to be too shameful for them all to be working together. So they weren't even working on live patients in some cases. They would have anatomical cadavers. They would basically mannequins rather, to try and learn how to do things like pelvic exams, childbirth, et cetera. But women of lower socioeconomic classes, immigrant women, women of color, they were considered to be less, stigmatized by this. If it was shameful for the well-to-do, wealthy white women to go before the class or to participate in medical research, then many researchers and students used women in disadvantaged categories. Okay, and there was also a belief in the 19th century when people began to use general anesthesia in ways they hadn't before. There was a belief that civilization, the extent of being civilized, actually made somebody more susceptible to pain, both sensitivity to pain and endurance of pain. And so one of the reasons why Sims felt justified in his experiments was he did not believe that the women he was working on felt pain in the same way that, civilized, quote unquote, white middle-class women would. And that belief had gone unquestioned and still is in many parts of the world unquestioned, right? Many of these assumptions stick with us today, even with a much more, with a much more sort of comprehensive scientific medical worldview that definitely was not mainstream at that time, so.
Yeah, if you look at the maternal mortality crisis, which is disparately affected Black women, some of the issue is that doctors, 95% of which are not Black doctors, don't listen to and don't believe Black women's pain and reports and listen. So, that trickles from back then to now. And also you look at opioids, and it's a weird paradoxical thing that people of color have been under-prescribed opioids, including for sickle cell disease, for which it's appropriate. Whereas white people have been over-prescribed opioids. And so there's that, so that these things that you think are these crazy historical beliefs and how can anyone believe them have been persistent in our medical culture. And, and that's why we have to go back and talk about, Marion Sims, or talk about these 19th century beliefs, because they, in order to root them out, right, and prevent people from getting hurt today by them.
It's important for us to have a historical context to what's happening today, to see it transition. The other one that comes to mind, and I put it in the resources, Henrietta Lacks, who they took cells from her when they were doing a cervical exam, and she ended up dying from cervical cancer. But to this day, they're still using her cells. So when you looking at cures for cancer, polio, other kinds of diseases today, that's as a result of them taking the cells from an African-American woman who had no idea. And her family didn't find out until like 15, 20 years later that they're using her cells today for research, continued research. And then the other thing it made me think about is my undergraduate research was on population control programs and birth control. And so it was really interesting to look at the different forms of birth control. And the majority of the forms of birth control, the pill, Depo-Provera, all those were tested on women of color before they were approved by the FDA. I didn't get a chance to actually take a picture. I wanted to take a picture. I had taken a lot of ceramics class, and one of our projects was to do something and to display a message through that. And so I did the torso of an African-American woman's body. And on that, I did African body paint. And within that paint, I put all the forms of birth control that were tested on women of color. And they had no idea. And so once again, it's populations that are disenfranchised, that are low income, and then also may not be aware. So we talk about health literacy, and they don't know what they're doing. You know, I'm sure a lot of you have heard of La Operación, which was the sterilization of Puerto Rican women going in, you know, I want a form of birth control, and coming out and not being able to have a child at all for the rest of their life. And so it is important. I'm happy that we're here having this discussion around having that historical context to what persists today and what is still going on today.
I don't want to backtrack. You all have mentioned some examples of like health disparities and health inequities in women's health. I think we have a slide actually of the definition. If one of you also could maybe explain like what exactly is that? What is meant by health inequity? What is meant by health disparity?
You go back one more.
Sure. Is
it health equity? So this actually I got from Robert Wood Johnson Foundation. I think it's important that understanding the difference between equality and equity. And a lot of you may have already seen kind of a depiction like this before. It may be like this, or with little kids, there's another one with little kids. And so equality, you see in the picture that everybody has the same thing. Whereas equity, it's being able to access, but you may have to make some variations of what that means in terms of access to what it is you're trying to do. And so, you know, the definition is up there in terms of health equity means that everyone has a fair and just opportunity to be as healthy as possible. And this requires removing obstacles. And so we have to be intentional about looking at what are those obstacles to be removed. And so I thought that was neat. Dr. Martin Luther King says, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane because it often results in physical death. And then if you go one more then to health, actually back the other way, you had health disparities. Then understanding the difference between health equity and what we're talking about access, and then health disparities. And so health disparities are those differences in health status between people related to social demographic factors, race, gender, income, and geographic region. So health disparities can have impact on health equity. And so when we look at health equity, we need to come back and look at disparities. And you may have heard the term before, social determinants of health, SDOH. And so that falls into line here, is that we're looking at those things that impact you know, people and their access to health equity. And so then what is it for social determinants of health? You may have heard the term before, but what does that really mean? So that we're clear: healthcare access and quality, education access and quality, social and community context, the economic stability neighborhood and built environment. And so just being clear about what that is. And sometimes when you think about access, I know for some people it could be semantics. So what I think is access may be different than what you think about access. So always when you're having discussions around health equity and access is kind of being clear and put it out there in terms of this is what I see as access, and clarifying that with whoever you are in discussion with about what that means as far as access, because sometimes, you know, I may come at it very differently, whereas someone else, maybe from a socioeconomic standpoint and understanding education. Okay, well, what that means where you live is very different. If it's public school, you know, even public schools where you live, you all know Upper Arlington is very different than Columbus City. I live in Gahanna, and I've seen a difference in what we have access to versus Columbus City. And so really being clear about what that means when you look at social determinants of health and access.
So you all have mentioned like different racial inequities. Someone talked a little bit about like socioeconomic status, how historically poor women, is that correct, have been researched on and sometimes on ethical ways. Was there anything you wanted to add like in that for socioeconomic inequities or racial inequities or just any other previous inequities that we've overcome that you wanted to touch on?
Well, I mean, when I talked about Sims, Deirdre Cooper Owens has written a book, the book, I would say, on Sims research called Medical Bondage. And she also talks about Irish immigrant women who were at the time in the 19th century that was the wave of Irish immigration. There was a famine there and there was mass immigration to the US. So there were women who had disadvantage due to their immigrant status. And so immigrant and refugee communities who lack access to may have language barriers, have different cultures, have different knowledge of how to get around and sort of in the United States or in a community to which they immigrate or are refugees. Those are issues. And I'd also like to call attention to, in Dr. Nick's slide from RWJ, ask you to think, what does it mean? Like, think about what does it mean, difference between equity and equality? How do people have different needs? So my mother, for example, is an elder, and she has different needs than I do, health-wise, more. And so there's age related. My friend who's been living with HIV for 25, 30 years has different needs than I do, maybe, or women, cisgender, transgender women have different needs, so that equity means not that everyone gets the same, because my mom, again, doesn't have the same needs as I do. The elders with COVID vaccination, elders went first because they had greater need, right? Immunocompromised people went first because they had greater need. And so think about, I would just, because our society tends to think of everyone, well, we're all equal, but we all are also different. So anyway, just to think about that with regards to equity and disparities.
I also think when you look at marginalized groups, we can't overlook people identified as disabled in a very broad spectrum of terms. And you can definitely see this in the history of eugenic sterilization. So you had mentioned and that kind of selective sterilization policy is ongoing in many parts of the world, even in the United States. But in the early 20th century, a number of states had involuntary sterilization laws on the books, right? So people who were, women especially, who were institutionalized for developmental disorders, for acquired disabilities, or even those who were just identified as wayward, whether it was they were, sexually deviant or identified as sexually deviant, they could be sterilized against their will without their knowledge. And in the US South, there was a phenomenon that a civil rights activist who was a sharecropper in Mississippi, Fannie Lou Hamer, she popularized as the Mississippi appendectomy, where women, largely women of color, but not exclusively, a number of poor women there as well, white women there as well would be targeted with this. They would go in for abdominal surgery, whether it was appendicitis, whether it was benign, fibroid tumors or something else, and be sterilized without their knowledge while they were under general anesthesia. And I think I have I can't remember where I put it in my notes because I have too much paper in front of me. But Fannie Lou Hamer, in a testimony she gave in the 1960s, she experienced it herself in 1961. And she argued, she believed that within her community, a majority of women had undergone this kind of involuntary sterilization. 6 out of 10 women, I think, was the number that she quoted. And again, that is largely anecdotal, but from a source that would have known, who would have been on the ground to gather that kind of anecdotal evidence. So yeah, there are a number of groups who, for one reason or another, are deemed to be more suited, or had been deemed to be more suited for these kinds of very selective healthcare decisions, often without their knowledge or without what today we would consider informed consent.
And it wasn't just individual sort of bad doctors, or we think of Mississippi like just backward doctors. No, it was policy, and it was based in ideas of eugenics, which were this idea that there were fitter people who were and less fit people to reproduce. That poor people were inherently inferior, that people of color were inherently inferior. When Dr. Nick talked about the birth control testing, how it was tested on women in Puerto Rico, partly because it was funded by people who were favoring eugenics, mainly, partly, and it's hard to to unpack it all, because birth control was also seen as a right that women had, like a right of access to birth control later. But the early tests were were partially because of a belief and a philosophy of eugenics, this idea that you had to control the population of non-white third world populations that were exploding, that women were not capable of controlling their own bodies, inherently. So we have to get to that these are ideologies and philosophies that then become poisonous to people's bodies and people's lives.
So you talked a little bit historically about inequities, specifically like racism, how it's affected women of color. What does that look like today? Like, what are persisting health disparities that are still here because of this history that you all are giving an overview of?
There's some that I mentioned, and I know these ladies too are familiar with it too, is, maternal morbidity and mortality. We've talked about that a little bit. Infant mortality, chronic conditions, unfair treatment by healthcare professionals. Black women in terms of complications with birth, are 3 times as likely than white women to have complications. And we know mortality, infant mortality, same thing with Black babies, twice as likely to die. Chronic conditions, just looking at the things like diabetes, hypertension, cancer, those things, the rates are much higher than the general population. And when I mentioned unfair treatment by healthcare professionals, that gets back to not listening in terms of, for example, pain medication. What's happening today, I don't know if some of you saw that during COVID, there was actually an African-American female doctor that was in Indiana University Hospital that actually made a video. She had requested pain medication. She ended up dying. And so they were very mean and demeaning to her. And she's like, I'm a doctor, an MD. I mean, I know what I need in terms of some pain, but they did not want to hear her. So the other one that comes to mind is I actually have strong ties to the Brazilian community. And I had a friend who had to have surgery at a hospital. She did not speak English. And so she had broke her ankle. And I remember before she went into surgery, that the person that was taking her back looked, my mother was there with me and said, well, we're getting ready to take her back. So kiss her, do whatever you people do before I take her back. And I was like, you know, and this was about 7 or 8 years ago. You know, someone is talking to us like this. So it's whatever you people do, you know, go on and do that before I take her back. So, you know, those kinds of things, I don't know, ladies want to contribute in terms of what's still going on today.
I think there's also a great disparity in access to preventive care today. And, you know, the example that I go to for that I think is very apropos for this discussion is treatment of breast cancer. Because for about 100 years, the overwhelming response to breast cancer, any diagnosis of breast cancer, was the radical mastectomy, was removal of an entire breast as well as surrounding tissue in the pectoral muscles, even some of the ribs. It's very invasive, very disfiguring, and very dangerous, right? And it really wasn't until the 1960s and 70s that researchers started to actually consider here's a picture of the first birth control pill, the Enovid, that was tested in Puerto Rico. Also very dangerous, by the way, and has been discontinued, but I'll talk about that later.
High dose, right?
Yeah.
And the doctors and researchers didn't listen to the women.
No, they did not.
Oh, they're overly emotional.
Yeah.
That's why they're having these bad.
Having thromboembolism. And yes, right. That's too many emotions, right? Sorry, I'm being sarcastic if that did not come across to the web people. So, you know, it wasn't until the 60s and 70s that more people said we can have better outcomes with early detection, with radiation treatment, with lumpectomy, right? Removing just individual, you know, cancerous lumps rather than entire breasts. But there was a, you know, significant reluctance to invest in that kind of research, right? To undo the older surgical traditions. And really the fact that preventive treatments or, you know, solutions for breast cancer, like, you know, routine mammograms, et cetera, the reason why those exist today is because of grassroots activism, because of women and, you know, allies in the medical field who were saying this is something we need to do. And it still is not very widespread. There still are lots of cases of breast cancer that go undetected that could have been addressed much more easily, much more safely, particularly in marginalized communities, right? But yeah, the story of Enovid, this is the pill, the one that was, you know, appears on the market in 1960, is credited as helping the sexual revolution and second wave feminism. And many women supported it, many women wanted it, but it was causing significant side effects, right? From, you know, mood swings and depression to heart disease, to serious cardiovascular risk. And many physicians simply refused to do the research into it. And to, in fact, the reason why I put this here is because Enovid, after a campaign by a female health journalist, Barbara Seaman was her name, she testified before Congress, and she was one of few women who was actually able to do so, to talk about experiences she had reported on with Enovid. She insisted on warning labels, and Enovid was the first medication, the first prescription medication to have an FDA warning label affixed to it, warning of the side effects.
And since then, I don't want people to come away thinking that all hormonal contraception is just like this now. It has been changed.
Oh yes, it's very different.
Yeah, so that has been changed. Although, I mean, there's some, you know, people do get side effects from it, and there are other forms. Anyway, I wanted to talk about, build upon what Dr. Nick said about maternal and infant mortality. It's an area in which I've worked. And there's a slide about the CDC's campaign about listen to her, hear her. It's hear her concerns. And so from a public health perspective, there, you know, you'll hear maternal death is rare, which means that it's a rare outcome. So most women who give birth these days survive it, right? But still, over 700 women die each year in this country in the first year after giving birth from conditions related to pregnancy. And disproportionately, those women are Black women. And so there has, and there's what you call, there's a maternal mortality review that states are supposed to do. Not all states do it well, reviewing each case, what could have been done differently. And they found there's a lot that could have been done differently. You know, women's, and number one, women's symptoms need to be listened to. Women need to be educated on the symptoms that could be dangerous, but also other people around the women, not just healthcare providers, but partners, but family members can also be involved. So for example, when something doesn't feel right, when there's a persistent headache, that could be something called preeclampsia, you know, that it's this you know, and gestational diabetes is another one, like that high blood pressure that can be fatal. So a persistent headache or persistent pains, you know, and the campaign is really to listen to women and to act quickly, and for healthcare providers to be trained, but also for the lay public to be trained for a culture change, to understand that this could save a woman's life. And there are many, many more cases of severe maternal morbidity. So a woman can have, you know, a serious health complications from birth that make her unable to care for her baby in the early months and weeks after birth, which is important, which could, you know, lead to disability. So all of that is this campaign. And infant mortality is also, Siri. I'm showing my age. I'm like, okay, stop talking to me, computers. So infant mortality. The disparities, as Dr. Nick said, are twice that for Black women versus white and Asian women. For Hispanic women, they're in the middle between, but again, it's about 10 in every 1,000 births among Black women. So it's still rare, but it's preventable, because we know in many countries like Finland and Japan, it's like 2 and change per 1,000 births. So we know there's some non-preventable infant mortality from congenital defects. You know, there's some babies that just due to genetic defects cannot survive outside the womb for a long period. But in addition to that, there are babies who die from sudden and unexplained infant death syndrome. Sometimes the women are not educated as to, you know, placing a baby on their back. The baby is not provided with the proper crib. If a woman who's experiencing homelessness goes home with her infant, she may have no choice but to share the couch with the infant, and that increases the possibility that she could accidentally roll over and suffocate her baby. And if you've ever had a baby, as I have, you know, you don't sleep a lot, and that could happen to anyone. So you want to prevent that and have a crib available for every baby. So, and educating, you know, things like that are preventable. Other things, you know, early treatment. If there's a child who is born with certain conditions, that the child be in the ICU, you know, and that again, babies, regardless of color or national origin, be treated the same by healthcare providers. So all of those things are important in terms of reducing existing health disparities. And it's, you know, and in public health, we talk in technical terms, but when I think of it as, you know, as a mother, like I don't want other mothers to experience the loss of a baby if it's preventable. You know, I don't want other fathers or siblings. I mean, and I think we need to humanize it more in health and talk more about it in terms of people's stories and real people, and how we can work in our communities to try and reduce this.
Well, I think it's also important that we've all given examples primarily based on women's reproduction, right? Women's obstetric or gynecological health, women's health as mothers. But, you know, there's very widespread disparities in other parts of the body as well. You know, women have hearts and lungs and abdomens and, you know, brains and everything else. And I mean, if you call the Wexner Medical Center at OSU and you're on hold, which I do a lot, and I'm on hold a lot, you'll hear this very cheery voice saying, do you know the signs of a heart attack in women? Because women often present that I've had a heart attack and it didn't hurt. And it took me a while to be seen for it because they're like, oh yeah, you couldn't have a heart attack, right? What you're describing couldn't have been a heart attack. And it's important when we talk about issues of equity, when we talk about health literacy, it's also important to note that in some areas, the research simply hasn't been prioritized for women. They're only just starting to recognize that there might be some significant differences. And, you know, for women, like because of, you know, the way that they are socially trained to present to physicians, you know, women may be less likely to say, my chest hurts, or women just be less likely to feel the pain. It's hard to disaggregate that, but those differences do exist. And they, you know, I think when we look at the Our Bodies, Ourselves movement, which began in the late 1960s, they first began publishing in the early 1970s, you know, there was this idea that women's health was primarily about reproductive matters, but that simply is not the case, right? A lot of research and thoughtfulness needs to go into disparities in other avenues of health as well.
Yeah, and I guess I need to point out too, or just state that in one of the slides I have put when we talk about inequities and marginalized groups is the issue of racism. And that's interpersonal racism as well as structural racism. It has a direct impact. The American Public Health Association has come out and noted that racism is a public health issue. It's linked to, there's lots of research that physician out of Harvard has done some research in terms of racism and just toxic stress and what that does. I know that there's been research on African-American women having low birth weight babies. And that came out of looking at, and they controlled for sociodemographics. So these are educated women, economically in a good position, still having low birth weight babies. And all they can contribute it to is the stress of every day waking up and being Black. And so what does that mean? We know that that's linked to cardiovascular. There's been some links to other things as it relates to maternal health and those complications, you know, stress and hypertension and what that does when you're pregnant and those kinds of things. And so there is the individual and what you experience as an individual in terms of racism and how that impacts your overall health. But then there's structural racism. So as we look at these things and we talk about the history and the ideology that continues today in thinking about certain groups are inferior to other groups, that still continues today as we give you examples of the interaction of healthcare professionals, you know, how people are treated, you know, are they treated like human beings? Or the other thing is we talk about research, you know, yes, clinical trials, you know, are women of color involved in clinical trials so that we know some of these things. I know there was a female nurse that spoke a couple weeks ago with the Kirwan Institute over at OSU and talked about breast cancer clinical trials and research and how we've been lacking in terms of having women of color in those trials. So we know that it is effective for different groups because people respond differently to different medications. So really being, and I put it in the resources is Dr. Kamara Jones, who was previously the president of the American Public Health Association, has done some phenomenal work. If you ever want to see that talks about racism and health and looking at it at different levels, she is excellent. The other one is Dr. Nancy Krieger. She's on there too, just looking at it. And so it's important as we look at the past, but we look at what's going on today, that we are active in terms of identifying it and what can we do to be proactive and make a statement about what's going on individually as well as structurally, the racism that exists.
So just to wrap up, like moving forward, I know each of you have talked a little bit about like the education piece of like moving forward and women's health. We talked a little bit about the activism piece. Did anyone want to add to that as far as like moving forward? Because of course, in everything, there is hope to have a more improvement.
Definitely, there's lots of ways. I have put this up there. First of all, social responsibility. Just if you aren't, you know, not everybody's the one to, you know, go to the march or the protest or sit out in front of somebody's office and hoop and holler or whatever. But just educate yourself. You know, like we gave you resources today. Some you probably already are aware of. Others, it may be an opportunity for you to say, hey, you know what? I want to find out more about this, or I want to find out more about the history of this. Just really, what can you do to educate yourself about what's going on? Next would be continue the work, as I mentioned, with health equity, social determinants of health. You know, what can you do in terms of a student, you know, being involved in groups, being, you know, looking out there and seeing what's going on. Is there an opportunity for you to stand up at something? If it's a health professional group, if it's, you know, lobbying certain things, you know, as we look at, you know, I know it's controversial, but abortion rights and how people feel this way or whatever, but however you feel, you could be a part of that. If it's standing out there in the group that's standing in front of the Congress people, or writing a letter, or calling your Congress people, that's important. Cultural competency and bias training. I know that here at Columbus State, it's a lot. We're trying to do that with the employees, our staff, students as well. I think that that's important. Sometimes I know for me personally, in my experiences, it just may be an ignorance, you know, and there has to be a comfort level. I found myself within the past couple of years calling some folks out with a way that interaction wasn't appropriate. You know, it was hard for me because I was like, how do I tell this person that they treated me this way? And it was a white male. And I'm like, you know, that kind of can be a little intimidating sometimes depending on the situation for me. But it was a win-win situation. Oh, I didn't realize that what I said, you know, came out that way. And so that kind of thing. And so we need to continue doing that in all areas, you know, healthcare area as well. Health literacy is so important, as she mentioned that, and we've mentioned that, just knowing what's important, you know, what is it as we talk about preventive care. I had worked in Massachusetts for the Department of Public Health and did outreach education for their breast and cervical cancer. And it was interesting because it's very diverse. And I saw that the African-American population was different than the Latino. And then there was actually not Asian, but Vietnamese. The way that they did was very different than India, and the Chinese, and the way that they would do outreach around preventive care, the Native Americans. And so being important around how you help people to educate themselves in terms of health and taking care of their health. And it has to be, as we talk about equity, presented in a way that they understand. That they can then be proactive in their own healthcare research, continue the research as it impacts different populations, including them in the research, clinical trials, as I already mentioned. And the last one I need to put down there is vote and vote and vote. You think about what right now we got, I don't know if you turned on it later, but we got some folks coming up, was it governor? And so, however you believe, you know, I'm not trying to be political, but what I want to do, and I have a 20-year-old daughter, is that it's not just the presidential election. You need to be at every single election. So these things impact what we're doing. You know, people have views about healthcare. We've talked about, you know, abortion. We're talking about, you know, critical race theory. Should we not? Should we whatever? And people, and I would say educate yourself on the issues as well. So if you're going to say something and you're going to take a stance, please say it with some facts based on you did some research on what it is that you're speaking out about. And also, you know, so that is really important, is that you look at what people are saying, because once these people get in, when I get to the structural racism, you know, there's some folks that may perpetuate what's already going on. And so you had an opportunity, and people think, well, my vote doesn't count. Yes, it does count. It does. These people with the ads on the TV saying, you know, this way or whatever. And so those are things that impact the decisions that we make about our healthcare. You know, women in our bodies. You know, there's other people sometimes making some decisions that, you know, may not be the best for us as we do, you know, in terms of our health and our healthcare and how we take care of ourselves. But those are just my little tidbits on what you can do right now as you walk out this room.
We also will share in the chat, and also with everyone who's in person today, we have a really large list of resources, a lot of different readings if you like to read. For the sake of time, though, is it all right if I open the floor for questions?
I know
So
He had a question a long time ago, and I just wanted you to know that I saw you.
I saw you, Stevie.
I saw you.
Yeah, I mean, I feel like you guys have pretty much touched on it, but it was just alluding to like the fact that we've kind of got a lot of examples of like what hasn't been working and how it felt like the individual's like right to care and like, you know, like what you were getting involved with was kind of either out of your hands or it was like, you know, due to some, I don't know if we're gonna say authority or like, you know, the doctor's got it here type stuff. But now with like initiatives like the informed consent and different things like that, like who do you feel like are leading those? Or are there any other initiatives like that that you feel like are bringing a little bit more understanding or like opportunity for like an individual to get involved in there? You know, that might be a little blurry. Let me know if I gotta.
I mean, I think that's an excellent question. And I think when you look, especially, I'm an historian, so I got to respond with stuff that happened before any of us was born. But when you look at like the civil rights movement, you know, there were significant health initiatives in a lot of civil rights movements, whether it was Native American rights, whether it was disability rights, and you know, even the Black Panthers, they initiated community healthcare clinics in a lot of Black communities around the country. And it was largely due to their efforts that sickle cell research became a focus in the second half of the 20th century. So I think, you know, being able to talk about health issues as community issues, as issues of civil rights, it has been and will continue to be really important, right? Because as Dr. Jones said at the beginning, you know, Western medicine always has been about isolating certain conditions in individuals, right? And trying to kind of disaggregate that from the collective, but really that's a false division to draw, right? And wounds don't heal if you don't expose them to light. I mean, that literally and metaphorically, that's true.
I think we can take one more question, and then if anyone has additional questions, you're welcome to leave them in the chat, and we can respond at a later time via email. Does anyone else have any questions that they would want to? Yes, go ahead.
For those of us going into the medical field, as well as with advocacy as a primary goal, being blessed to be here in America with the diversity that we have, how do we respect people's cultures? Example, female circumcision or genital mutilation, where even the women have come to accept that as okay and normal because it's part of their culture. How do we help educate them to understand that it's okay to stand up for your rights? Because in a lot of these countries, it's not okay for that.
Yeah, you have to, I guess, be humble in how you approach that. And I know, and I'm hearing that my public health degree is in international public health. And so in learning about that, you know, I was taken aback, you know, and I'm strong and I'm vocal or whatever, but you have to respect the culture, you know, that you are in. When I mentioned outreach to women in breast and cervical cancer, in certain Asian populations, when the women go in for the exam, the man goes in too. Nobody is looking at my wife's parts without me being in the room too. And so you have to know and you have to understand and just respect that. And it may not be something that you embrace, but you have to support them in the way that they embrace that, while maybe at the same time saying, you know, kind of, this is the way that we do that here, or things are here in the United States, you know, and in a subtle way, you know, educate them. Some women have come to learn, oh, I do have a voice if they've come here or whatever. And some they may never. And then some, it may take some time. And so I would say just continue to be humble and to do that. I had a professor that told me he went to, I can't remember what country in Africa, but they had a water issue, and the water was contaminated. They had malaria. And so they felt, in working with the community, they needed a football field. And so it wasn't his place. He was coming from the United States to their country. And you're going to tell me, that what we need is a football field. We don't care we're getting sick from malaria. But he had to continue to be there with them. It took some time, but after a couple of years and a presence in that community, they felt the trust, and there was a way that he helped them to understand, yeah, there is something wrong with the water. Yeah, we're going to do something about the water. And so just like I give that example, the same thing here, as we have people of different understandings and backgrounds and whatever, that just being humble. And so it's a way that you present something, and it's not like, this is what you need to do, and this is the way it needs to happen, but like, oh, that's the way. And maybe it's a win-win situation. Let me learn from you. You tell me about your experience and what you're used to, and let me share with you how things are from a medical perspective here in the United States.
Well, we are all out of time. I want to thank everyone for coming in person today and also on Zoom. In the back, there are cookies from Freedom a la carte. You're welcome to grab a water with you, as well as take the cookie if you want it to go. I think that is all. I'll just thank you all for being here, and happy Women's History Month.